Done your resume kotti vallu unmute kottaru. I'm sorry. So and you have to understand that it is reabsorbed at the visceral pleura layer. Okay, so primary production is from the parietal pleura. So pleural fluid is produced from the parietal pleura, and it is reabsorbed at the visceral pleura. So it is by the lymphatic drainage that happens along the lines of parietal pleura. So first you have to understand the fact I told you before, that unless there is a large accumulation of the pleural fluid inside the space, it is not visible on a PA chest erect film, right? So remember, unless there is a large effusion that has been collected inside the pleural space, you cannot detect it on a PA chest film erect. So the other modalities that what we actually do is that there is another view that is actually called as the lateral decubitus view. Okay, the lateral decubitus view is the principal kind of investigation to actually detect the minimal pleural effusions. Okay, so minimal pleural effusions are detected on a lateral decubitus view. Okay, please look into the please look into your chat box that I have written some kind of a sentence so that you can actually follow what I have been talking about. Excuse me, come on everybody, respond please. Respond please. Yes, lateral decubitus view. Okay, lateral decubitus view is the only view that is available, or say that is most choice of investigation for a detection of a minimal pleural effusion. What is a decubitus view is that, okay, let us say that the patient, exactly, that is a patient, let us say if he has got a problem beside the right pleural space. Okay, let us say you are suspecting that the patient has a pleural effusion on the right space. So now you wanted to investigate what exactly if there is a pleural fluid that has been accumulated there or not. So how do we actually do it? We ask the patient to lie on the right side. Okay, we ask the patient to lie on the right side, and then the X-ray is being exposed as same as the lateral film itself. So you are going to do it over his axilla, and then the rays are going to just pass from the side of the body. Uh, you just ask the patient to lie in the lateral position, then you try to do the X-ray as a PA view. Okay, let me show up the picture so that you can actually understand what I'm talking about. It's not the same like the lateral view, but just only you ask the patient to lie down on the lateral side. Just let me send you a picture so that you can actually understand what I'm talking about. Okay, please look into your message box. I have sent you a picture. So this patient is suspected for a right-sided pleural effusion. So you ask the patient to lie onto his right side. Then lift his shoulders. Then what you do is that the projection will actually start directly from the back side, so that can yeah, I know, I'm sorry for that, because you know, because I have been come down to a place of the road. Okay, let me try to, you know, change my room. Just give me a minute. Just give me a minute. So is it still noisy now? I think it must be fine now, right? Okay. So if you look at this picture, what you can actually understand is that the person is lying onto his right side. Okay. The person is lying onto his right side. Then we take the picture as if we are just doing it in an PA view. Then we get an image that is called as the lateral decubitus view. We get an X-ray somewhat like so we get an X-ray somewhat like this. Okay, please look into your message box once again. So we get an image something like this. So you cannot actually, this is not written as PA view, but you have to look at the film as if he is just lying down itself. Okay, so this is one of the best views for detection of most of the pleural effusions, a minimal pleural effusion, or sometimes you can also say there is a minimal pneumothorax or a pneumoperitoneum. You can actually try to accommodate it. Another oxidative fluid on the radiograph itself. So it is the physiological mechanism on the pathological examination of the contents of the pleural fluid is the one that differentiates between the transudation and exudation. Unless we are going to find out the secondary, okay, unless we are going to find out the secondary features, that is how we are trying to differentiate and take a guess if it is a transudative fluid and an exudative fluid. Okay, then site specificity. What exactly do we know that the site specificity is? That it can actually happen, okay, certain diseases tend to produce the pleural effusion either only on one side or the other. So we can have two patterns here. It can be unilateral or it can be bilateral. Okay, it can be unilateral or it can be bilateral. Pleural fluid accumulation can happen on one side of the pleural space, or it can happen on the both sides of the hemithorax. Right-sided and left-sided pleural effusion both can happen. Okay, if it is seen only on one side, we call it as unilateral pleural effusion. If it is seen on both sides, we call it as a bilateral pleural effusion. Okay, so that's the first pattern you have to remember. Next, what we are going to remember is that, okay, we have to know about the diseases that actually causes a bilateral pleural effusion. Okay, the first thing is that we try to understand when whichever the kind of diseases that actually produce a lot of changes in the hydrostatic pressure or the changes in the osmotic pressure. Example to say congestive heart failure, as if in cases happening with hypertension. Okay, all the patients that are being suffering from hypertension, and mostly congestive heart failure is the one that actually produces a remarkably significant bilateral pleural effusion. Okay, right? You call it as bilateral pleural effusion. What is the most common cause? It is congestive heart failure. Then there is another disease which is related to the multi-system involvement, which is actually called as systemic lupus erythematosus. Systemic lupus erythematosus or lupus erythematosus, we call it as SLE, is the one that also produces bilateral pleural effusion. We will be talking about SLE in the skeletal musculoskeletal system radiographs, but you have to understand that it is also one of the conditions that will actually cause a bilateral, usually bilateral pleural effusion. But whenever it is causing unilateral effusion, it is mostly seen on the left side. Okay, pleural effusions that are related with the lupus erythematosus is mostly on the left side. We will be talking about the reason why this fluid is present on the left side more in skeletal radiographs when we are trying to observe, try to learn about the synovial fluid and other things. Okay, we will talk once again talk about this one there. Okay, then diseases that can produce effusions on only one side. Okay, it is mostly unilateral. Tuberculosis is one of the most common condition that causes unilateral pleural effusion. Okay, and then pulmonary thromboembolism. Remember, this is a very emergency situation. Okay, pulmonary thromboembolism is a very classical disease that actually happens because of the blockage of the pulmonary artery by a thrombus. Okay, is the one that actually causes thromboembolism, which usually causes unilateral pleural effusion. And then there is another condition that is called as a trauma. Trauma means to say whenever there is a rib fracture, or let us say a patient came up to the hospital with a suspected rib fracture on the left side lower ribs. Okay, and now you see that there on a preliminary examination of the radiograph, you saw some kind of a fluid and a hyperdensity that is present along the lateral sides of a film in the periphery. Now, it might be happening because of the leakage of the fluid, leakage of the blood from the thoracic, coastal capillaries. Okay, so now that one will start to accumulate only on the left side. So unilateral pleural effusion, trauma, yes, it is present, but most common one is tuberculosis. Okay, diseases that produces left-sided pleural effusion. Remember, pancreatitis, distal thoracic duct obstruction. Okay, distal thoracic duct is the biggest and the largest lymphatic drainage channel. Okay, so distal thoracic duct obstruction, and then there is a condition called as the Dressler syndrome. Okay, Dressler syndrome, pancreatitis and distal thoracic duct obstruction and pancreatitis are the ones that actually causes a left-sided pleural effusion. Okay, remember this as a fact. Don't get into the much more details. Okay, but remember, left side pleural effusions are caused by pancreatitis, distal thoracic duct obstruction, and Dressler's syndrome. Right? Okay. Now look at here. This is a peculiar image. A left-sided pleural effusion. Okay, you see here. You see here, this one, the left hemithorax is completely opacified here, right? And you also see here, there is a placement of an artificial cardiac pacemaker device. Yes or no? Can you see it? This some kind of a thing that looks like a mouse here is the one which is actually called as artificial pacemaker device. artificial pacemaker device are installed in patients with bundle branch blocks, or sometimes also atrial fibrillations or Wolff Parkinson White syndrome. Okay, any kind of conduction disorders. Okay, any kind of conduction disorders that is related to the SA node AVN, which actually causes atrial fibrillation. Okay, and ventricular fibrillations or Wolff Parkinson White syndrome, WPW syndrome, you call it as. So in those patients, you actually install an artificial cardiac pacemaker. And now what actually happens is that it happens after a transmural myocardial infarct. What is Gestural syndrome? Gestural syndrome is nothing but a syndrome that typically occurs after 2 to 3 weeks after a transmural myocardial infarct. It can occur in following a pericardiotomy, removal of the pericardial layer, and occurring in patients with the coronary artery bypass graft surgery. Okay, CABG, we call it as CABG, coronary artery bypass graft. Okay, so that is the one. If there is an accumulation of pleural fluid, we call it as a Dressler's syndrome, or we call it as post myocardial infarction syndrome or post pericardiotomy syndrome. Okay, Dressler syndrome, remember that it causes a left side pleural effusion. Radiographic findings are here that there are the left side, there is a white density that is blunting or obscuring the costophrenic sinus, and then I can see a U shape to it. So this kind of U shape actually indicates this is the fluid level. Okay, because I think you have usually made this kind of observation. Let us say you have taken a water in a water bottle and fill it to the half. Then what actually happens, there is a fluid level, right? You can see the fluid level actually moving quite clear on it. So that is how it is actually called as a meniscus, right? The fluid level inside the water bottle or in a capillary tube is called as a meniscus, right? It will be an inverted, it will be in the U shape, right? So this one is also indicating this U shape is actually showing up as the meniscus. So such kind of sign is actually called as a meniscus sign. Remember, meniscus sign. Yeah, surface tension. Because of the surface tension, every fluid actually shows up such kind of a surface tension. So this is called as a meniscus sign. And you also have to understand in the meniscus that the lateral end of the meniscus is higher than the medial end. Okay, that is how you recognize if this is a pleural fluid or if this is some kind of an atelectasis. Okay, how can we differentiate a pleural fluid from an atelectasis? Is that the lateral end of the pleural fluid is higher than compared to the medial. And also this fluid level changes according to this side that the patient is lying. Okay, so the change in the shape of the meniscus usually indicates that it is a fluid collection but not a mass or a atelectasis. Atelectasis and masses do not change their positions, but a fluid actually happening because of the gravitational pull. So that's the reason they change their position. So that's how we are going to differentiate between a meniscus and a tumor kind of hyper opacity. Okay, right. The combination we'll actually have is the chest pain, fever, pleural effusion, and patchy lower lobe airspace disease and pericardial effusion several weeks following a myocardial infarction, or an open heart surgery should suggest a Dressler's syndrome. Okay, and this one generally responds to the high dose of steroids. I'll not get down into the pathophysiology of that one, but remember, left-sided pleural effusion is caused by Dressler's syndrome. Okay, this may be a picture-based question. Okay, how can I recognize this one as a Dressler syndrome? Because you see here there is an artificial cardiac pacemaker. I can see the meniscus along the black arrow, and an opacified hemithorax. And you can also typically see in this picture, there is no tracheal deviation and mediastinal shift. Okay, because this kind of fluid is not really massive. Okay, it is just a moderate pleural fluid accumulation. So this much of pleural fluid is something around like 150 to 250 ml. Okay, so unless this much of amount, it is not visible on a chest radiograph. Okay, that's what I already told. I told you that this patient has a dual lead pacemaker. Okay, right. Abdominal diseases that is related down to the liver and the ovaries. Okay, please write down here a very important point. There is a condition called as Meeks syndrome. Okay, Meeks syndrome is a condition that causes ovarian tumors. Okay, ovarian cancer. Generally, it is associated with the ovarian cancer, and it causes the right-sided pleural effusions and ascites. It is a triad, okay, triad of Meeks syndrome, okay, which is also called as Meeks triad, okay, and you can generally say it as the ovarian tumors along with the right-sided pleural effusion and ascites. Okay, to understand the pathophysiology of Meeks syndrome, you can get down to the Wikipedia page. I'm the one who wrote that Wikipedia page about Meeks syndrome. So maybe if you have time, you can just go learn about Meeks syndrome. Okay, Meeks syndrome is called as the ovarian tumors. Okay, ovarian tumors along with the right-sided pleural effusion and ascites. Then we also have rheumatoid arthritis. Rheumatoid arthritis is an inflammatory condition of the rheumatic tissues, okay, or of the joints. Okay, joint inflammation is called as arthritis. It can also give out an effusion which is remained unchanged for years. Then we have the proximal thoracic duct obstruction. Okay, now recognize how do we recognize? Pleural fluid on a chest radiograph actually, like I said, depends on the position, the force of gravity, and the amount of pleural fluid and degree of elastic recoil of the lungs. Okay, which means to say atelectasis is a secondary sign. Then the change in the position will change the meniscus and the force of the gravity. Okay, most dependent areas has got high gravitational effect, less dependent areas has got less gravitational effect. Fluid starts to accumulate down in the dependent areas. Okay, it will be let us say it will be accumulated down in the spaces. Okay, what is the space that is present down in the abdomen? It is the Douglas pouch, right? Douglas pouch, did you hear this name? Douglas pouch. Okay, that is the dependent area in the abdomen. Costophrenic recesses in the thorax is the dependent area. Okay, right? Okay, try to get back to your anatomy book and try to find out what is a Douglas pouch. Okay, Douglas pouch is the dependent area. It is the area that is present between the urinary bladder, okay, and the intestines. Okay, there is a small space that is present between the urinary bladder and the intestines. It's the small place that is where usually the ascitic fluid starts to accumulate first. Okay, right. Then subpulmonic effusions. Subpulmonic effusion actually that happens beneath the lungs, between the parietal pleural layer and the superior surface of the diaphragm and the visceral pleura under the lobe of the lungs. So this one is called as a subpulmonic effusion, which usually is called as the blunting of the costophrenic recesses. Okay, subpulmonic effusion. So this is the one we actually call it as. Okay, right. Retroperitoneal pouch, yeah, that's the same name. Okay, retroperitoneal pouch, that is usually present down. It is more, appropriately seen in case of females, and in males also it is present between the bladder and the intestines. Okay, that is called as a retroperitoneal pouch. It is also called as a Douglas pouch. Okay, right. So like I have been talking about, if there is a subpulmonic effusion, like we usually say, subpulmonic effusions generally are not detected down on conventional radiographs, okay, except for contour alterations, which we call it as the blunting of the costophrenic sinuses. Okay, last time we have seen in the other class about this one. So blunting of the costophrenic sinuses itself is called as the subpulmonic effusions. So that is the only radiographic we see. Now, right-sided subpulmonic effusions, you can see here, this one is, the meniscus is not seen here, but the meniscus is seen here as this way. You see here? The meniscus is seen along the white arrow, but the black arrow is the one that is actually showing up as elevated, which means to say this is happening only because of the problem that is present down in the lower lobe of the lungs. Okay, so the fluid starts getting accumulated and accumulated in the pleural space. There is a counteractive atelectasis of the left lung, so that's the reason you see it is not going extended beyond the minor fissure. So this one is the minor fissure line, and here is the actually the meniscus. So you see here, this one also looks like a transverse S sign, but this is not the golden sign of S. Golden sign of S is happening in the upper lobes here, but this one is called as a transverse S sign, which is also happening in pleural effusions. Okay, that is how you differentiate between them. Now, did you understand this picture here? Okay, you see here, this is the blunting of the costophrenic sinuses. The costophrenic sinuses, okay, here is the meniscus, and it is not extending beyond the minor fissure. So which means to say the problem is present below the lower lobe, in the lower lobe of the right lung. Okay, so that's what this picture talks about. And you can also see here in the lateral position, okay, in the lateral position, this solid white arrow here is the one that is actually showing up the posterior costophrenic sinuses. Okay, the evaluation of the costophrenic sinuses are present mostly on the posterior side. That's the reason the best investigation of choice for visualizing a chest X-ray is a PA view, because the maximum volume of the lungs is present down on the posterior side, and the dependent areas are also present down on the posterior side. That's the reason when visualizing a chest X-ray, we will be choosing a PA view because of this logic. Okay, because the maximum volume of the lungs is present on this posterior side, along the costophrenic sulcuses are also present on the posterior side. So that's the reason we take a PA view. So in this lateral view, we actually see that here, this is the meniscus, and this one is not extending beyond the minor fissure. Okay, not extending along the minor fissure, and the major fissure is the one that is actually obscuring the shadow, right? So both of them, it is not extending beyond the fissural lines. So that is the what do you say, the radiographic feature, right? Left-sided pleural effusion, in this image you can actually see here there is a little blunting of the costophrenic recesses on the left when compared to the right. You see here the right costophrenic recess is quite sharp. You see, this one is quite sharp, like a needle, pinpoint needle, we call it as. But you look onto the left, there is an opacity that is filling up the left costophrenic recess. Okay, and you can also see this air that is present down, the gastric bubble, that is air that is present down here in the left hemidiaphragm. So this one is actually causing the obscuration of the shadow along the lateral border of the left diaphragm. So that is one of the sign, and here is the pleural effusion. Okay, can you see this? Did you understand this image? Okay, so by this I can actually say obscuration of the shadows of the diaphragmatic shadow and the costophrenic recesses is the one that is the diagnostic feature for pleural effusion. Okay, you didn't understand this one? Okay, let me repeat once again, Benedict. You see here, compare it to the costophrenic recess that is present down here. See, this costophrenic recess is a pinpoint shaped one, okay? This one is pinpoint, right? Can you see here the V shape on the right side first? So any kind of a normal costophrenic recess has to look pinpoint and clear. There should be no density that is present here, okay? And at the same way, now look at the same area that is present down on the left side. Generally, if there is no fluid collection here, it should look symmetrical like the right side, yes? But on the left side, this one is not looking that way. I can see that there is a white area that is present here. First, there is an opacity that is obscuring the shadow of the left costophrenic recess. Yes or no? Okay? Yes or no? Yes? And the other thing, I can also see that the lateral border of the diaphragm is also obscured. Yes? Right? So these by this I can actually understand this is a pleural fluid. Okay, and I can almost see the, extending. It is extending here. It's the meniscus here almost. Okay, and then actually it says that the distance between the hemidiaphragms is also decreased. You see here, this one. See the dotted arrow, double black arrow. Okay, this one is actually saying it as the apparent left hemidiaphragm. The left hemidiaphragm has been raised. Okay, because the left hemidiaphragm has been raised because of the fluid that has been accumulated, and there is a counteractive atelectasis. Okay, this space, the lower lobe, it has any kind of a fluid will have counteractive atelectasis. And when we are learning about the atelectasis, we also learned that the diaphragm will be elevated on the ipsilateral side itself, right? So that's the reason this left hemidiaphragm is also elevated. Now, is this clear picture? Benedict? Yes? Archana, is this clear now? Is this both clear now? Right? In atelectasis chapter, we came to know that if there is an atelectasis, that one will pull the parietal layer also, right? So that's the reason there is an elevation of the left dome of the diaphragm along with the blunting of the costophrenic recesses on the left side. By this, I came to understand it is a left-sided subpulmonic effusion, okay? Right. So I think this is not necessary. We're talking about the same picture. All the radiographic, I told you, there is a blunting of the left-sided costophrenic recess. Okay, and on the lateral image also, we can see that the rounding of the diaphragmatic recesses on the posterior side. Okay, remember, on a lateral projection, we have it as the rounded hemidiaphragms. Okay, rounded hemidiaphragm, and the contour of the diaphragms is lost. Okay, contours of the diaphragm is lost because of the effusion that is present with the major fissure. Okay, this is the major fissure, right? This major fissure actually comes down like this, right? So that's the reason there is the rounding of the hemidiaphragmatic shadow. So that's what we call it as a meniscus. Okay, so left-sided pulmonic effusion. Generally, in undergraduate levels, you should be able to interpret a pleural effusion on a PA view. Okay, right? Okay. Now, how can I recognize the blunting of the costophrenic angles? And if the effusion grows in size, which means to say there is a accumulating of fluid keeps on happening, and it fills first and blunts the costophrenic sinuses on the posterior side, like because that is the dependent area, and visible on a lateral view of a chest. So if it is visible, the blunting of the costophrenic recesses on the posterior side, something like this in this image, you can generally say that there is 75 ml of fluid accumulated within the costophrenic sinus. Simple, Remember, the first blunting of the costophrenic sinuses means to say there is 75 ml of fluid that is accumulated. Okay, then you see here, quite simple. This one is the costophrenic sinus, but it became opacified and there is a rounding. So which means to say this is a blunting of the costophrenic sinuses because of accumulation of 75 ml of the pleural fluid. Okay, so this one is called as the meniscus sign. See it? The lateral area is higher than the medial side. Okay, right? So this one is also the posterior side and the anterior side. We are talking about the lateral film here. Okay, the posterior side, always the lateral borders or the posterior borders are higher than the anterior and medial borders. So that is how the meniscus, it is a rounded shape. Okay, that is how a meniscus also should look like. So this indicates the fluid level. Okay, now it is also seen, you can also see that the normal hemidiaphragm, okay, the normal left hemidiaphragm is siloted. So siloted sign is also applicable here, and you can say the effusion is on the right side. Okay, a sharp posterior costophrenic angle. Okay, a sharp costophrenic angle here, you can see here, this one, and there is a blunting around this place. Okay, so both of them actually indicate that the effusion is present down on the right side here. One siloti, the other, the left one is clear, and here this is present down on the right. So these three signs indicate that this is present down on the right side. Okay, next, the blunting of the costophrenic angles, if it reaches higher levels, the effusion reaches higher levels, 300 ml of fluid, it blunts the lateral costophrenic angles visible on the front radial chest radiograph. See here, if it is blunting of the costophrenic angle, you see here, lateral borders, if this has been blunted, it means to say there is 300 ml of fluid. Okay, this is sharp and clear, but you see here compared to this x-ray here, okay, this one has obscured, the lateral borders are obscured, so that's the reason we call it as something. Exactly. Yes, Benedict, yes, you are correct. Yes, you are correct, right? So this one is 300 ml of fluid, right? And now we can say here, aerated lung generally in such kind of very smaller pleural effusions. Okay, we can say this as minimal pleural effusion. Okay, not minute. Minute is different from minimal. Okay, minute should be less than 75 ml. Okay, minute should be less than 75 ml. Minimal means to say 75 ml to 300 ml. Okay, so they can be visualized as a meniscus. Okay, so which will usually cause the blunting of the costophrenic angle. Okay, right. I think even though we are talking about, I think I have already described these signs here, so let me skip off this here. Okay, now you have to remember another thing here. There is a blunting of the costophrenic angle. Okay, you see here, this is a very typical radiograph. There is an atelectasis. Okay, there is an atelectasis and also accumulation of the pleural fluid. Okay, unlike the meniscus appearance, unlike the meniscus sign, there is another sign that is called as the ski slope appearance. Okay, ski slope appearance means to say the skiing. Okay, the skiing, you know, the ski actually has got a ramp and a slant way. That's the same way I can see it is a slant density here. Okay, so this one actually happens due to the pulmonary scarring. Okay, it can happen because of a previous infection or a previous surgery or the blood that is accumulated down in the pleural space. So this one, you have to just remember, do not get into the pathophysiology, okay? Or just try to remember the image as the way it is, okay? Let us say if you have given this image and say what exactly is this one, you have to mark it as the ski slope appearance, okay? Do not try to interpret a lot, just remember it as a fact. Ski slope appearance happens because of previous infections and surgery, which is due to scarring, okay? Which will do not have the meniscoid appearance of a pleural effusion. This one will not show as a meniscus sign, but will show up as a ski slope appearance, okay? Right? And this fibrosis, it will not change the appearance or the location with the changes in the patient's position as a free-flowing pleural effusion would. Okay, a free-flowing pleural effusion would change the position of the meniscus, but this pulmonary scarring or the fibrosis or the scope appearance will not change in its position if you change the position of the patient. Okay, that's why it is typical, right? Okay, the meniscus sign, we already talked about it. The pleural fluid appears to rise higher along the lateral margin. That's what I have told before, and than it does in the medially. So the higher level of the fluid is present always on the lateral sides than it does on the medial. Okay, so this produces a characteristic slope or the rounded like density, which is called as the meniscus. So meniscus sign is a characteristic feature of pleural effusion. Okay. Now, in lateral position projections, what actually it assumes a U-shaped. That's also we have seen in the picture, right? And equally high both anteriorly and posteriorly. Unless there is a large pleural effusion, both levels, anterior and posterior levels, lie on the same level. If there is a higher accumulation on the frontal radiograph, lateral position is high than on the medial. But in the posterior lateral projection, you can see that the anterior and posterior levels have the same level. Okay, right? So that is what the behavior of a meniscus is. So identifying an abnormal density that demonstrates meniscoid shape is strongly suggestive of a pleural effusion. So the confirmatory diagnosis of a pleural effusion, what is the confirmation radiographic sign? Meniscus sign. Okay, you have to remember it that way. Meniscus sign is seen in. Okay, the question will be asked like this. Okay, the confirmation of a pleural effusion is done by, the answer is meniscus sign. So that's how it is, right? Okay, so you see here, lateral margins are higher than on the medial positions. Okay, so I can see this one is a meniscus, and there is a blunting of the costophrenic angle on the right side. There is a hyperdensity that is blunting down the costophrenic angle on the right side, and the lateral margins are higher when compared to the medial margins. So it is called as a meniscus. So can I confirm this as a pleural effusion? We take a guess. Because the blunting of the costophrenic recesses is present, so there should be more than something around like 300 ml of fluid accumulated here, right? Okay. See, that is actually because of the surface tension. Okay. Why is the meniscus upwards? No, meniscus is not upwards. It is an U shape. Okay. It is a U shape. It is happening. It actually fluid takes such kind of a meniscus as a U shape because of the surface tension. Okay, meniscus takes a U shape because of the surface tension of the fluid. Okay, okay, let us say the crest is an elevation. Okay, crest is an elevation. Crest is an elevation and trough is a depression. Okay, so it's a concave. Okay, it's a concave shape, right? It's not convex, Benedict. It is not convex. It is a concave shape. You can also call it as a trough, okay, which is a depression or a U shape, and it actually looks like the same, like the, yeah, Aman has got the best explanation. It's looks like the same like water in a glass. Okay, right? All right, you see here, In the lateral sides, both the anterior and the posterior levels are almost present at the same height. Okay, is this clear, Benedict? Now, downward meniscus. Where did you read that one? Meniscus is always downward. There is nothing that like called as an upward meniscus. Okay, Benedict. Fluid achieving or assuming a U shape is called as meniscus. It is not called as downward meniscus. Okay. It is looking U shape, right? Even in a glass of water, it is looking U shape. Even in the capillary tube, it is U shape, right? It is the U, the depression is the concavity is present onto the downward side. So that's the reason you call it as meniscus. I think you are mixing up both the things. It is never called as a downward meniscus, and there is nothing that is called as an upward meniscus. Okay. No, it is not downward meniscus or upward meniscus. The depression, this is not mercury, right? We are not talking up mercury here. We are talking about the pure form of fluid, right? See, that one, yes, you will be talking down in that is the one we are talking down in the physics class, okay? But this is not a physics class. This is a radiology class, and we are dealing about with the normal fluid. Yes, you are correct. The meniscus in mercury is above. Yes, that's true. But generally, fluid, all the fluids will have meniscus downwards. Is this clear, Benedict? Okay. Right. Right. You see here, like I said before, CT is the confirmatory diagnosis, right? CT has got better sensitivity. And remember, can somebody tell me what kind of window mode are we looking at here? What is this window mode? Look at the picture and tell me what is this window mode? Nashra, why do you think it's a lung window? You see here, the lungs are black. The lungs are black. So which means to say I am looking at a mediastinal window. In a lung window, it does not. The lungs look white. Okay. This is a mediastinal window. Okay. Right. You see here, fluid density. Whenever we are trying to analyze the fluid density, we are looking at the what do you say? We are looking at the soft tissue window. We also call this as mediastinal window, as soft tissue window. You see here, this is the meniscus, see, and there is a gray-like hyperdensity that is present here. When compared to this one, this is a hyperdensity, right? When compared to the density of the lungs, we call it as a hyperdensity, okay? So there is a fluid-like hyperdensity that is present down on the posterior surface of the right lung. And you see here, L denotes I'm looking at the liver. S denotes that I'm looking at the spine. Okay, so this is almost at the level of T12 thoracic spine. Okay, so liver, this is the upper border of the liver. I'm looking at the superior surface of the liver or the diaphragmatic surface of the liver. So you see here, that is the dependent area, right? So the patient is right now lying down in the supine position. And now where did the fluid come down? The fluid came down to the posterior side because of the gravitational pull, and it got settled down in the dependent area. So in a CT scan, where do I look at the fluid levels? I will be looking down in the posterior side. Is this clear now? Yes or no, guys? It is now, right? So on a CT scan, where do you accumulate the pleural effusion? We will be always accumulated down on the posterior surfaces. Okay, don't forget this. This is a hyperdensity when compared to the lungs, which are looking black. So lungs are black. So when compared to the shadow of the lungs, we call this one as a hyperdensity. So there is a fluid-like hyperdensity with a meniscus that is on the posterior side of the thoracic wall. So this is my radiographic feature, and it is happening along the level of the thoracic vertebrae, right? Is this clear? Is this interpretation clear now? Yes, guys? Right. Okay. Now, like I always said before, if there is an opacified hemithorax, yes, this one is an opacified hemithorax. But if the pleural fluid is extending down into 2 liters, there is a lot of fluid accumulation, continuous accumulation of the fluid that is happening in case of congestive heart failure patients. I am done in 10 minutes, okay? Because your class will be only till 4 o'clock, okay? I'm done in 10 minutes. Okay, right? So this one is actually, if there is 2 liters, then the entire hemithorax will be opacified. As the fluid fills in the pleural space, the lungs tends to also undergo a passive collapse. Okay, so counteractive atelectasis is also a sign of pleural effusion, right? That's what we actually saw before also. You see here, there is a tracheal deviation, there is a mediastinal shift, the left side hemithorax is completely opacified, and you see here contralateral tracheal deviation along with the contralateral mediastinal shift, along with opacity on the left side suggests to me this one is a massive pleural effusion. Yes or no? But if this could have been an atelectasis, it could be there will be an ipsilateral tracheal deviation along with ipsilateral mediastinal shift. If this I'm thinking about a pneumothorax, it will be having absent lung markings, looks down as a radiolucency, and there will be contralateral tracheal shift and contralateral mediastinal deviation, right? But this one is an opacified hemithorax. I think you already know about this one. We have dealt in my very detail in the previous classes. So you see here, this is not a pneumothorax. This is not an atelectasis. And this is indeed a pleural effusion where there is almost 2 liters of fluid that has been accumulated. Okay. So how do I know it? There is an opacification of the complete left hemithorax. There is a right-sided tracheal deviation along with right-sided mediastinal shift. By this, I came to understand that this is a massive pleural effusion. Is this clear, guys? That's how do you interpret the image, right? So this is a characteristic feature, and this patient actually had 2 liters of fluid that is collected, right? Now, you see here a large hemothorax. Generally, hemothorax is the accumulation of the blood inside a pleural space. Okay, it happens mostly in situations of trauma. And you see here, one thing I can see here that the heart is completely deviated down to the left side. Okay, this is right side, this is left side. The heart is deviated down to the left. So which is called as the left-sided mediastinal shift. Okay, left-sided mediastinal shift. And also you can see here when compared to this density is a little bit higher, right? This one is looking a little bit more of a gray than compared to this level here, which is marked down as F, right? So, and you see here, this one is the lung margin. A complete passive atelectasis of the right lung happened because of this massive pleural effusion. I think we learned about this in the previous class also. So this one, the changes in the density will actually show a much more brighter density than the fluid density. Generally suggests me that this is a hemothorax accumulation of the blood. Okay, I am also still looking in the mediastinal window itself. Okay, right. And you see here, this one is the fluid is whiter, okay, than the collection. Okay, the fluid is whiter than the collection. So that's the reason I can say it as a hemothorax, because of the separation of the blood products that will settle down. So this one patient is met with a trauma, and it is generally happening because of the lacerated intercostal artery. Okay, vein, artery, and nerve is the accumulation in the inferior angle of the superior angle and the inferior angle of the borders of the coastal cartilage, coastal ribs. Okay, then the middle one, which is say the vein, artery, and the nerve, that is the how the positions are from above downwards, right? So in the middle you have got the intercostal artery, and that one has been lacerated, which usually produces this kind of an appearance. Okay, right? Lacerated means to say torn, tear. Okay, any kind of a blood vessel, if it is being torn, we call it as lacerated. Okay, right. Lacerations means to say cut out or completely destroyed, right? So now loculated pleural effusions, this is the last type, I guess. Loculated pleural effusions are the one that is actually causing, if it is accumulated within the pleural space and has got adhesions, so which actually happens in an old empyema patient or a hemothorax. Okay, so which will usually limit the mobility of the pleural effusion, so that it remains in the same location no matter what the position the patient assumes. So I will show you up a picture of empyema, but first let us say loculated effusions can be suspected when an effusion has unusual shape and location in the thorax. The effusion defies the gravity by remaining at the apex of the lung even though the patient is upright. The loculation of the pleural fluid has got a therapeutic importance since they will be traversed by multiple adhesions. There will be adhesions. Okay, let us say there is a pus that has been accumulating, and the pus solidifies, and there is a blood inside the pleural cavity, and also the blood solidifies. Now that they will not change their position. That is the first thing that you will know. And if it is a fluid, it will look hypodense, and if it is a blood, it will look much more hyperdense, right, when compared to the surrounding tissues. It is, see, on a CT scan you have to remember the window mode, and you also have to compare the densities according to the structures that are present around them. When compared this shadow, if it is present down as high density when compared to the black density of the lung, you call it as hyperdense. But when compared to the fluid density is looking much more whiter, you call it as hyperdense. Okay, so always remember which way we are talking about, if we are describing it on a CT or if we are describing it on a chest radiograph. Okay, and now day one will be traversed by multiple adhesions. They will be restricted by the multiple adhesions, and now it will not be free flowing as the other effusions. Okay, if we look at the picture we can understand. You see here, look here at the both black and white arrows. You see here, this one is actually, this is a very typical shape which is not seen as a pneumonia. This one is also not a space that is actually having, assuming the atelectasis either, right? And this is also not showing up down. Yes, it is showing up a fluid density. This is hyperdense when compared to this area. It is hyperdense, and you see here it is having a rounded shape, but it is present on the higher sides of the body. It is present down in the upper lobes of the hemothorax. Now, but they are trapped inside the pleural space. So now such kind of an effusion is generally called as a loculated pleural effusion. They will not have the effect of the gravity. Is this clear? So this is a loculated pleural effusion. You can also call it as an encysted pleural effusion, but still they will have the meniscus, on the above areas. Compared, you see here, the lateral margin is much more higher than the linear medial margin. So it is a meniscus. Okay, it is a meniscus, right? So this one is a loculated pleural effusion, but they are just restricted down in the spaces itself. Okay, so that's the reason. So loculated pleural effusion, those still have, they will have a meniscus that is defying the that is along with the effect of the gravity here, but here they do not have the effect of the gravity, and they always are present in the upper ways, in the upper lobes. So that's the reason you call it as a loculated pleural effusion. Just remember examples. Loculated pleural effusion happens in case of hemothorax and empyema. That is how you have to remember. Okay, I think I already explained it. Even if the patient is standing, this is an upright film, but even if the patient is standing upright, but still you can see the meniscus levels here that is present down in the upper lobes itself. So by this, we can actually call it as a loculated pleural effusion, right? And then this one, it's a 2 marks question. Remember, try to understand this one easily. I think we have already done this before. Let us say if there is a tumor inside a lung. Okay, will the tumor change its position if I am making the patient lie in supine position, and if I let the patient lie inside the it's standing? The tumor generally won't change its position, right? But if it is a pleural effusion, will it change its position? Yes or no? Yes, right? If it is a tumor, it will not change. If it is a pleural effusion, yes, it will change. Now, what we actually do is that, let us say, take a look at this image. You see here, on the first view, when I don't have any kind of a history of this patient, but I am having only this X-ray itself with me. And now what actually happened is that this is a standing view, okay? This is a standing view. Now what happened here, there is a well-defined, sharply marginated area, okay? A well-defined, sharply marginated area, a hyperdensity that is extending beyond the minor fissure. You see here, this is the minor fissure, and you see here, this one has got some, oval shape, eclipse shape, okay? It was showing up down as an ellipsoid oval shape, and you see here, it is extending beyond the minor fissure. And you see here, this one has got a U shape downward like this. So this one is very sharply demarcated, and it is a hyperdensity. On the first view, I can take this one as a tumor. But let us say, if I change the position of this patient, okay, if I change the position of this patient, what actually happens is that this one is completely gone. I cannot see this kind of mass right now. I cannot see this kind of density that is present down, which means to say the fluid, since this is a fluid, since this is a pleural fluid, what actually happens is that this one drains from this major fissure, minor fissure, and gets settled down into these areas. Since the fluid will flow along the fissures, so what happens is that if I change the position of this patient, all this fluid that has been collected here will start to disappear now and will start getting collected down here. So by this, I can understand that this is not a tumor, but this is a pleural effusion. So that's the reason I call it as a pseudotumor. Okay, I call it as a pseudotumor. The pseudotumors are generally happens if the fluid is present down in the minor fissures. Remember, okay? If pseudotumor or the encysted pleural effusion will happen if there is a fluid that is present down in the minor fissure, which takes down the lenticular or oval shape. It is clearly demarcated. It has a sharp margin, okay? And it will also have a meniscus, and it does not extend beyond fissure lines, but will change their shape. But they will change their shape and will completely, the density is completely vanished if I am changing the position of the person. So such kind of a tumor, it is present in one position and it is not present in another position.
So that's the reason I call it as a vanishing. Okay, I also call it as a vanishing tumor, and they are also called as pseudo tumors. So visceral pleural effusions are called as pseudo tumors. Okay, it's a definition. So generally, they also give away, okay, those tumors or that hyperdensity is also gone whenever I have treated the main important underlying cause. For example, to say if the patient is suffering from congestive heart failure, I have treated the patient with, furosemide, potassium sparing diuretics along with beta blockers. Okay, and I have also controlled the hypertension. I have controlled the fluid with hydrochlorothiazide, and the patient has got normal BP. The patient's cardiac output is quite good now. The ejection fraction is also tend to be satisfactory. Now, when the underlying condition has been completely treated, the fluid that I'm looking here is gone. So one, along with the changing of the position, or when you are treating the patient for the known cause, when this density is gone within no time, it is called as a pseudo tumor. Okay, so you have to know the definition. The change in the densities, sorry, the absence of the density when the patient's position is changed or the underlying cause has been treated. The loss of a density, tumoral density, by changing the position of the patient or treating the underlying cause of the condition is causing the pseudotumor. Best example is congestive heart failure. Okay. Next, the last one, very simple. If there is both air and if there is both fluid that are present together, you call this condition as a hydropneumothorax. Okay, it will be asked as a fill in the blanks. If the presence of air and fluid is present inside the pleural space, what do we call this condition as? We call this condition as hydropneumothorax. Okay, so when does this actually happen? It happens because when you are trying to treat a patient because of previous pleural effusion, so it means to say the patient has undergone a therapeutic procedure called as thoracentesis. So now there is a meeting of the external environment, external atmospheric pressure to the pleural surface. So that's the reason the air from outside the body comes down into the pleural space, and there is already fluid that is present here. So now the air and fluid are visualized together. So this one happened because of the doctor's intervention here, because I have done a surgical procedure called as thoracentesis, or to insert a tube which is called as positive pressure chest drainage tube. Okay, positive pressure chest drainage tube, or we call it as positive pressure ventilation that has been created. Okay, we call it as PPV, positive pressure ventilation. Okay, right? So I have inserted a chest drainage tube, and that one actually during this procedure the air has entered down into the pleural cavity. And then traumas, yes, in case of trauma, a piercing trauma, penetrating trauma, or in case of a surgery, yes, you will have a hydropneumothorax. Okay, hydropneumothorax has got both the features of the pleural effusion and pneumothorax. Where there is air, you will be having absent lung markings, you will be having absent lung markings and clear rib shadows. Okay, along with contralateral tracheal deviation and mediastinal shift. And in the dependent areas, you will be finding out hyperdensity, meniscus sign. So both the features of pneumothorax along with pleural effusion will be seen, and it will show up an air over fluid interface. Remember, air fluid levels are seen in case of hydropneumothorax. Remember, hydropneumothorax is the air and the fluid that is present down in the pleural cavity. Okay, right? And then CT is generally utilized here. Last time, I think it was Shafiq or Hisham who was talking about the cavity, right? When we are talking about the cavity, I said that it has got a thin wall and there is no air fluid level inside the cavity. Yes or no? Who is this guy? I think it's Hisham, right? I said there the cavity has got a thin wall and it has got no fluid level, right? But generally, abscesses are the one that has got an air fluid level. Okay, abscesses, generally speaking, because most of the abscesses will form a granulomatous reaction, finally causes the gangrene, right? That is also the problem happens in caseous necrosis also. Gas gangrene, Clostridium difficile, aspergillosis, all of this one caseating necrotic reactions, any kind of a bacteria causing caseous necrotic reactions or a gangrene formation will generally release the gas. So that one is called as an abscess. Yes or no? Abscess is nothing but a granulomatous reaction with a caseous necrosis in it. But a cavity is a liquefactive necrosis. Yes or no? Right? It is a liquefactive necrosis where pus is released. But abscess, pus is there and also gas is released. So that's the reason in abscesses we will find an air fluid level. Is this clear now, Hisham? Why the cavities do not have an air fluid level? Because of the liquefactive necrosis in them, right? But an abscess is a gas gangrene formation, but that's the reason they will have an air fluid level. Okay, so how do we differentiate an lung abscess from a cavity? Lung abscess has got an air fluid level. We will be dealing that in tuberculosis patients also once again. Okay, right? So generally you see here, hydropneumothorax, I can see the lateral margins of the lungs here, clear rib shadows with absent lung markings, and I can also see the meniscus. So this is the region, and I can actually say that this patient is happening because of the previous thoracic surgery, because I can see the metallic sutures here along the sternum. So open thoracotomy has been mentioned. Okay, thoracotomy, he has undergone a procedure called as thoracotomy. Thoracotomy means to say opening of the chest cavity. Let us say he has undergone a carotid artery bypass graft, or maybe a condition for pectus excavatum or pectus carinatum, or let us say that the patient has undergone a valvular replacement surgery, okay, prosthetic valve replacement surgery, right, in case of bacterial endocarditis, right, or rheumatic heart disease. All these conditions will have to open up down your chest cavity. Or if he has got an atrial septal defect or a ventricular septal defect, all those are the conditions which will do thoracotomy. In such kind of a conditions, you will open the sternum, you will check out the sternum, you will open the thoracic cavity to have an access down to the mediastinum. So in such kind of situations, air has escaped down, and right now, after you close down the chest, some air has been left out, and you see here the lateral margins of the lungs are quite visible, and you can see absent lung markings, and I can also see the hyperdensity. So both the features of the pleural effusion and the pneumothorax has been together. So that's the reason I know this condition is as a hydropneumothorax. Okay. Well, they were saying that the patient was stabbed on the right side and there is a moderately large pneumothorax, which is shown as the visceral pleural line. Okay, but there is no subcutaneous emphysema here, which is also fine. I can understand it. But he has undergone a thoracotomy. Maybe there is a large, since the patient was stabbed, right? We are talking about the same patient. Since the patient was stabbed, and there is a lacerated right artery, right, intercostal artery. So to suture that ligate that artery to control that bleeding, maybe thoracotomy must have been done. And so that's the reason I can see both pleural effusion and hydropneumothorax. Okay. So I think that's it. We have done with the complete chapter. So this is a very quite easy. Pleural effusions and atelectasis, pneumothorax, all these three can be asked as a case sheet or asked as an image based questions. Okay, right? So to read this chapter once again, it is quite easy, something as easy as pneumothorax itself. Atelectasis is the only difficult part. The difficult parts are only pneumonias, okay, and interstitial lung diseases. That is the difficult part in chest radiography. Pleural effusions, pneumothorax, and atelectasis are not really very difficult. They are quite easy and logical to understand, but there is a lot of differentiation diagnosis. We will take time for pneumonias. Pneumonias are difficult to understand, even though it is a very simple chapter. They are difficult to understand for differentiation. So next class, I think I will try to mostly try to accommodate my time. I think in mostly 1 o'clock on Monday and Tuesday's classes. If there is any change inside in the class schedule, I will just let the monitor know. Okay, the class will be in Monday on Tuesday itself, that is for sure. But if there is any schedule depending on my schedules, okay, generally I said it is at 1 o'clock, right? Let us say it is mostly at 1 o'clock itself, but if there is any change during the 1 o'clock schedule, I will just let the monitor know it on Sunday itself. Okay, mostly by Sunday night I will tell the monitor. If it is then, if I cannot accumulate my time at 1 o'clock in the afternoon, what I will do is that I will come down as usual as at 10 o'clock. But if it is not possible, I will be doing it at 1 o'clock. Okay, I will just let the monitor know and let it announce you in the group. And one another thing I just wanted to say is that you see here, you guys have to understand my schedules are getting more and more difficult. So that's the reason I am trying to accommodate my time. Okay, I am trying to accommodate my time, because you have to understand one thing, Dr. Dinesh is not available, right? So I am trying to accommodate for Dr. Dinesh as well. So that's the reason you have to understand my hardships here. And if Dr. Sahil and Dr. Moxie Doxy are present here, you see here, you fight and you argue among yourselves, but you have to understand my hardships as well. I'm trying to accommodate time whenever I can. Do you get this, guys? Right? I'm trying to complete the chapters. You see here, I can, yeah, sure, I will do this lecture also. And see, I know maybe you see here, my problem is not about taking the class. My problem is accommodating time. And other thing is that this, these classes are difficult to understand. I don't know if you were able to follow other classes or not, but my subject generally needs a lot of observation and a lot of explanation. Okay, I could have asked you guys to read, but see, most of the people have been sending me messages and saying, sir, we cannot understand the images. We don't know how to interpret. So that's the reason I'm taking a lot of time for you guys to understand. Hope you guys understand this part. I could read the slides and go off too. I can complete the 28 chapters like within 10 days. I can just read the slides, do not explain anything in the image, do not explain any the logic of the pathophysiological mechanisms. I can do that too. But when you are revising these chapters, it will be completely zero for you guys. You can't understand because it is very difficult for you. So please try to cooperate with me. Okay, you have to understand that I have been also working. I am trying to accommodate time whenever I can, and I am trying to complete your syllabus as fast as I can. Okay, right? And other thing, yes, you guys have a schedule, but you see here, you are supposed to take the classes when you have no practical classes right now. If you have the practical classes, you see all these conditions, all this explanation can be done in the practical classes. But since we are not having practical classes, I don't know what kind of plans you have all the day. Yes or no, guys? So people, whoever want to attend the classes, attend it. Whoever want to argue, argue. Who wants to go against me, go against me. But I can't have a choice, right? People are welcome to listen to my class. People are also welcome to get out of my class if they don't like it. And other thing you have to understand is that I am not teaching from China. I am teaching overseas. I have my own schedules to keep on too. I'm trying to accommodate for you guys, right? So if you got a problem, okay, if you got a problem with my schedules, you talk to your teaching affairs. If you don't want me to teach, talk to your teaching affairs. Got it? Yes or no, Mr. Sahil? You have a problem with my teaching, please talk to the teaching affairs. Say that I cannot torture you guys with the sudden class. Yes, man? Sahil, are you here? And Moxie Doxy, are you here too? You have a problem with my schedules? Talk to the teaching affairs and tell them. Right? Man, guys, where are these guys? Please respond to me. I have been talking about 2 people. Yes, I can understand you have got subjects to study, but if you are sitting down in an university, your schedules are much more busy than the way they are now. Okay? See, it's not about the teaching, then what is it about? Is it about just because I have been announcing the class just 1 hour or 2 hours before? You have got 4 practical classes, man. You see here, you have got 4 practical classes for radiology. All other subjects do not have practical classes. You have 4 practical classes. Even in the practical classes also, we are doing all this explanation stuff. In the class, we don't do this explanation stuff. We do all this explanation stuff in the practical classes. Since you have got no practical classes this time, so that's the reason I'm trying to combine both of them. And that's the reason, yes, our classes are taking time. Yes, I know. But were you able to read Benedict? Were you able to understand the images by yourselves? Are there any guys who were able to understand the images all by themselves when they are trying to read the slides? If yes, no, you can't understand. So then that's the reason, cooperate with me. That's the reason I'm accumulating my time to you guys. See, comparatively with other subjects, I'm not even giving you assignments. I'm just giving you 25 questions. Yes or no? I have just given you MCQs. That's the reason. Okay, if you still guys have a problem with my schedules, talk to teaching affairs. Let them find a solution for your problems, not me.